Assalamu alaikum. Okay, so treat to target in childhood SLE, I have no disclosures. Bismillah, we'll start the talk by answering this question: do we really need targets, and explaining why do we need these targets. Moving to a brief history on target development, then target attainment in childhood SLE and its impact, CLDAS definition, and finally ending with some challenges that we might face in the future, and the proposed treat to target strategy. So childhood SLE survival trends have improved over time. This is a fact. Maybe Dr. Najla showed us that it did not improve in lupus nephritis. Yes, we'll explain that. So there are multiple cohorts that showed the improvement in survival. This is one of the cohorts. It's an Indian retrospective study over 23 years. So they divided patients into early and late according to the year at diagnosis. And as you can see, there is significant improvement in survival in the later cohort compared to the earlier. Another Thai cohort over 31 years, again retrospective, showed also an improved survival rates in the later cohorts, and also a decline in the mortality rates, so very significant, from 50% down to 10% in 31 years. So overall, there's improvement. However, if we compare lupus to other chronic diseases or other rheumatic diseases, we are still way behind. So a group studied prospectively, which is more accurate, the mortality trends in SLE. So again, they divided early-late cohorts versus non-lupus controls. At the same time, in a separate study, they also studied RA versus non-RA controls prospectively. And as you can see, yes, there is an improvement in lupus. However, we are nowhere near improvement in RA. So we are really still behind. So that despite the survival improvement, mortality rates remain high. Further, in pediatric or childhood SLE, the mortality rates are much higher. So it's up to 6-fold higher, as you can see in this standardized mortality ratio. Now, one UK multi-center prospective epidemiological study of childhood SLE looked at into damage 1 year after diagnosis. And this was a prospective also, so it's more accurate. They found that up to 20% of patients already had organ damage 1 year after follow-up. And these patients were on ongoing immunomodulatory therapy and ongoing steroids. Most of these patients had any of the following domains, except for cardiovascular and ophthalmologic. Most of them, it was neuropsychiatric. So 1 year after diagnosis with the current standard of care is really concerning. What predicts damage in childhood SLE? There is more than one study, of course. There are lots of studies to try and predict the risk for damage. This is one of them. It's a retrospective study. It showed that one of the strong independent factors is the higher disease activity. So SLEDAI, the cutoff was here, SLEDAI 2K more than 12. And the median time was 6.5 years for damage. So an important goal in lupus is to control disease activity, which will ultimately reduce the disease damage, whether it's from medication side effects or it's from the disease itself. Different groups try to come up with some definitions in order to achieve that goal. So in 2016, the Asia-Pacific Lupus Collaboration proposed the LLDASH definition, which stands for the Lupus Low Disease Activity State. Around the same year, the European DORIS Task Force was called for and established, and finally in 2021, they published their definition. DORIS stands for the definition of remission in SLE. So throughout the years, we have more, or in adults, they have more than one definition for either low disease activity or remission. All these definitions have been studied for attainment, and the attainment level or the achievement was anywhere from 3% to 90%. Most of those was more than 50%. The two most universally adopted definitions are the DORIS, which stands for remission, as I mentioned, and the LLDAS for low disease activity. As you can see, lupus targets take medications into account, not as the other targets. So the target here is remission. If the remission cannot be achieved, then low disease activity is an alternative. What about pediatrics? Well, we do have some recent data in the past few years. So since 2021, we did have different cohorts. So there is the UK cohort, the Rotterdam, the Turkish, the Thai, and Cincinnati registry. I will start with the largest one, which is the juvenile SLE cohort in UK. So it included 430 patients. Again, it was a prospective cohort, so it's more accurate. Some of these were retrospective. And the attainment level, or the achievement, was 67% within a median time of 18 months. Moving to the Rotterdam cohort, 100% of these patients surprisingly achieved the LLDAS definition in median of 6 months. Turkish, 82%. Thai was 47%, which was the lowest compared to other cohorts in 12 months. Cincinnati registry, they compared lupus nephritis to non-lupus nephritis. So as expected, lupus nephritis patients achieved much less LLDAS definition. 2 of those cohorts also studied the remission definition, and they found that remission was achieved much less than the LLDAS definition. But overall, all concluded the same. LLDAS is achievable in childhood SLE. So in 2021, after the UK cohort that I have mentioned, the Treat to Target, or Childhood Treat to Target International Task Force was established and called for. All members agreed that the definition of low disease activity in childhood lupus should be based on LLDAS definition for the following reason. First, the attainability that we have mentioned in the previous studies over the past 2 years, and the associated improvement of these of LLDAS in adult data. However, they did some modifications in the definition to improve the applicability for our population while maintaining the alignment with the adult definition to ensure the collaborative work between us and their population. So the CLLDAS, which stands for Childhood Lupus Low Disease Activity, was finally defined in 2023, last year. I will go over each element and the important points that have been discussed. So first, starting with disease activity. So the definition is SLEDAI 2K 4 or less with no activity in major organ system. So major organ system being defined as no activity, no fever, renal, cardiopulmonary, or neurological and vasculitis. Now, GI and hemolytic anemia were part of the original definition in LLDAS initially. However, in 2019, the updated or the revised version, they removed hemolytic anemia and GI because they found that there is no additional predictive value when they added it to disease activity, and it was captured by physician global assessment. So the CLLDAS definition is consistent with the revised version, so we're not adding it, but it should be also kept in mind that these two should be looked for in the physician global assessment. All agreed that there are no new features of disease activity present compared to the last assessment. Physician global assessment, although the members were familiar with the 1 to 10 scale, they introduced the 1 to 3 scale, again to keep it consistent with the original definition. Prednisolone dose. Now, the maximum ceiling dose in adult LLDAS is 7.5 milligrams, which is relatively high for some of our patients. So they introduced a weight-based cutoff, which is 0.15 milligram per kg per day, aiming for the lowest dose among those two. Why is it important to discontinue or to wean glucocorticoid? We all know that there is no safe dose of glucocorticoid, so not the 5 milligrams that they said, not the 2.5 milligram, the only safe dose is 0 milligrams. It's not only the cumulative dose that matters, also the duration. So this study looked into the steroid-related damage in pediatric and adult lupus at the same time. You can see that there is significant difference and much more damage in pediatric compared to adult within the same time period. So in 10 years and 50 years, pediatrics always score higher in damage. Saying that, however, CLLDAS reflects good rather than perfect state. That's why they kept the prednisolone definition. So some patients cannot be controlled without glucocorticoids. The stable immunosuppression, meaning stable hydroxychloroquine, biologics, or immunosuppression, it is considered stable if the change is not due to disease activity. Rather, it's due to building up the dose or adverse events or adherence to therapy. So broadly speaking, adult definitions, they do have more than one definition, as I showed you before, but the two most universally adopted are the LLDAS and the remission on therapy. Why on therapy? They do have off therapy, but they found the remission is much less than the on therapy, and some patients will be harmed if you just withdraw medications just to reach the target. So they kept it as on therapy, but they do have off therapy as well. Now, in pediatric definitions, we already discussed the CLLDAS. But past year in the press meeting, they mentioned that in the future, we will have two remission definitions, so CCR and CCR0. CCR stands for childhood SLE clinical remission on medication, so on glucocorticoids, on immunosuppressive therapy. CCR0 stands for childhood SLE clinical remission of steroids on immunosuppression. So they are all the same. No disease activity is allowed. No new features are allowed. Immunosuppression should be stable. Physician global assessment less than 0.5 compared to the 1 in the LLDAS. And prednisolone dose should be discontinued in CCR0 while it's, the ceiling dose was reduced to 5 milligrams per day in the CCR. So why is it important to define and attain target in childhood SLE? Well, in adult, there are a huge amount of data, or there's a huge amount of data on the impact of target attainment, whether it's remission or low disease activity on SLE. It was associated with lots of benefits, so reduced flares, glucocorticoid, mortality, improved health-related quality of life, and much more than that. They also, in addition to looking at the impact, they studied also the effect of the time to reaching LLDAS. For example, this study shows the percentage of severe flares at any time while the LLDAS is achieved. And you can see that the earlier the LLDAS was achieved, the less reported flares, as you can see here. And also they found that patients who achieved LLDAS earlier also spent more time in that target and they had less glucocorticoid dose. So it's not only the target itself, the earlier the better. On the other hand, failure to achieve the LLDAS or the remission was associated with damage accrual and increased significantly in mortality up to 5-fold. One prospective cohort also suggested that failure to achieve LLDAS at 6 months is associated or a strong factor for damage at 12 months. So again, the time is important, the earlier the better. Now in pediatrics, remember the cohorts that we have discussed regarding the achievability or attainability. Some of those also studied the effect or the impact of these targets in the damage accrual and severe flares. Now the UK cohort studied 3 different definitions of low disease activity on those. And as you can see in the first table here, there's a significant improvement or reduction in the hazard ratio in severe flares and damage accrual. And they also studied the effect of the time spent in each target. And you can see from the schedule on our table, the second table, increasing the time from 10%, for example, to 80% will reduce the hazard ratio of severe flares from 0.68 to up to down to 0.05, for example, in LLDAS. And the impact of damage accrual was performed best by LLDAS here. The Cincinnati registry that compared lupus to non-lupus nephritis also concluded that LLDAS at baseline was a significant protective factor for acquisition of additional damage. However, lupus nephritis and pre-existing damage, even if they reached LLDAS, they will have high risk of damage. You can see that the survival probability is less for patients with lupus nephritis, even if they reach targets. So treat to target approach, is it a dream or near reality? Well, with every new step or every new, we do have some challenges. So this is the list of the expected challenges. I will explain everyone and the expected outcomes from those. So first is the attainability. We discussed that there are different achievement rates, anywhere from 50% up to 100%. And this might depend on the definition. So the remission is more stringent. As you remember, the swirl, the more you go in, the more the definition will be stringent. However, they all used LLDAS and they had different rates. So this might be due to genetics, ethnicity, socioeconomic status, access to care, as well as the heterogeneity of the disease. Whether it's severity or it is due to the manifestations, for example, lupus nephritis will achieve much less LLDAS. Second is the practicality. So is it practical? Well, in order to approach or achieve LLDAS, regular assessment with SLEDAI-2K should be documented, as well as physician global assessment. Now, SLEDAI-2K is not a practice for every physician on regular basis. However, there are online calculators, online applications for calculating SLEDAI within less than 1 minute. Sustainability. Well, achieving the target is one thing, and keeping that target is another challenge. There are some studies that suggested the minimum duration to reduce damage in the target is 2 years. So keeping the patient 2 years in remission or LLDAS is really challenging. Now, patient's perspective, one UK study also looked into the perspective of patients and families regarding the tier 2 target approach. And they all agreed that they would like their kids to be asymptomatic with no treatment side effect, mainly glucocorticoid and no organ damage. However, they expressed their concern that treat to target approach might increase the frequency of hospital visits, which will impact the school performance and also the parents' employment. And they also expressed their concern that the patient's outcome are not taken into consideration in treat to targets. It's only reflected by physician global assessment. So a strategy to facilitate the treat to target approach includes including the family in decision making, as up to 75% of patients will not adhere to therapy if they're not convinced with the plan. So communication in treat to target is key here. Now, over treatment. So there are 3 important questions. First, is it justifiable to change conventional therapy? Well, there is a potential risk that we are discontinuing or escalating therapy in a conventional therapy that might show effectiveness with time. On the other hand, if we introduce another medication or change it to another medication, that therapeutic might not really work for that specific patient. And also, we do have limited number of approved medications for childhood lupus. So with treat to target, the medications options might be exhausted rapidly. The second is how frequently should we assess and change medications? Well, the suggested duration is every 6 months to be evaluated for treat to target. But in CLLDAS specifically, they mentioned that the treat to target approach, the evaluation should be every visit. However, most of the studies in adults, it's 6 months. This is not a magic number by any means. Third, what is the boundary point between controlling the disease activity and inducing drug toxicity? Still, it's not clear. So physician global assessment, there's a challenge that there's an inter-rater discrepancy and variability, so it's not an objective, accurate way to measure the activity. Now, validation. CLLDAS have been proposed last year, but it's not validated still to our population. So the International Childhood SLE Treat to Target Task Force are working toward its validation. And currently, there is an ongoing randomized controlled trial in adult comparing the standard of care versus the remission and low disease activity. And it's a randomized controlled trial, so still we are waiting for the results. Now, in order for treat to target strategy to become achievable, there are 2 important elements that have to be fulfilled. First, establish practical and achievable outcome measures. Second, the way that we will achieve that measure by therapeutics. So a group, sorry for that, it was not like that. So a group suggested a treat to target approach. I'll just summarize it. So the first is consider the patient's need, personalized therapy. Again, I'm sorry for that slide. So consider the patient's need, make a personalized plan for the patient. Second is frequent assessment for the patient, and do not change the conventional therapy just to reach the target. You can just adjust the conventional therapy first and then alternative therapy. And the last step is consider the treatment plan and responses frequently. And again, the suggested duration or frequency is every 6 months. So in conclusion, the current care is not enough to prevent damage in childhood SLE, although mortality have improved, but still we are way behind in childhood lupus or in lupus in general. Adult SLE treat to target endpoints were associated with improved outcomes in childhood SLE, but we do have few studies, it's less than 10 studies. So currently or recently we have the CLLDAS definition, but still we need validation. So targets may facilitate more effective use of treatment in a structured way to control disease activity and to prevent organ damage. And that is the ultimate goal in lupus. Thank you very much.
Thank you so much, Dr. Al-Jain. We have 5 minutes before starting our next speaker. So any question for Dr. Al-Jain?
Assalamu alaikum, Dr. Al-Jain. It's very well done and very nice and informative presentation. My questions regarding what you mentioned, one of the limitations is the attainability. And one of the major advantage of having the clinical remission or low disease activity remission is to prevent damage and increase the survival and quality of life in these patients. But in order to have this goal, they should have a good time on attaining that definition. So probably there is a risk that if we try to reach this definition earlier by stopping or decreasing the steroid therapy earlier, we are probably increasing, there is a chance to increase the frequency rate and decreasing the time that the patient attain the definition of low disease activity or clinical remission activity. And probably this will end with having no benefit of getting this patient in this definition if they don't attain it for a long time. So we have to balance decreasing the treatment to get the target and to keep in a good dose to maintain the target, not only to achieve the target.
Yeah, I do agree. First, we have, like you mentioned, 2 steps. So first, inducing the target. But again, it's very difficult to decide, should we change therapies, discontinue steroid just to reach a target and a number. So the second thing I think is our population. Our lupus, I'm not sure if we have studies, comparative studies, but I think our lupus is more severe than the lupus. So withdrawing therapies fast may, yes, induce more harm. But here we do have an option with steroids. So they mentioned the 7.5. I don't think 7.5 daily is a simple amount for our population. It is a good amount. So maybe 5 milligrams will be considered low. But again, as you mentioned, I do agree with you. So it's difficult to maybe keep the patient at least 2 years in that target.
Thank you, Dr. Al-Jain, for this really comprehensive talk. My question, what was, during your review, what was the definition of off-therapy remission? Was it 6 months, or we have to keep the patient off therapy for how long?
Yeah, that
From
depends
different
on the what is the frequency that you will assess your patient. So, for example, in the tier 2 target randomized control study, what they did, maybe they have more accurate answers. So what they did is, if the patient is on standard of care, they will evaluate the patient every 3 to 6 months. This is their care. For us, I think as pediatric, every 3 months. In the other arm, in the tier 2 target, the approach that they use is that they will evaluate the patient almost every 1 month to every 6 weeks, which is less than the usual care. And they will upgrade their management, or they will adjust their management till reaching the target. Once they reach the target, it will be every 3 months. Now, in CLDAS, they just suggested that you should evaluate your patient for the target every visit, but they did not really specify a number. The number ranged in the studies between 3 to 6 months.
Any more questions for Dr. Al-Jain? Okay. Thank you so much, Dr. Al-Jain, for this informative